Hey everyone, this is Kirsten Logan, your friendly COVA training coordinator. Good to see many of you or see you online. We're having a little bit of an issue with people who aren't muted as they're coming in. So if I can just ask everyone to mute, and I see the note that we had some background noise. I think the settings when this was set up, people are coming in with their audio on, which is normally what people are used to. So if you're watching this presentation live and you want to use it towards COVA's voluntary victim advocate training, you can do that with no problem. If you are watching this later on our YouTube channel, we do hope that you find the information helpful. However, archived presentations may not be used towards COVA's voluntary victim advocacy certification. So with that, I'm going to introduce our presenter, Andy Greco. We're so thrilled she's here. She's going to tell us more about what a forensic nurse is. And I'm going to moderate the questions for her. We'll have plenty of time for Q&A, and just put your questions in the chat. We'll kind of take them at natural pauses. And with that, Andy, thanks so much. I'll turn it over to you.
Well, hello, everyone. Thank you so much for having me here today. It's quite an honor to be asked to speak to you guys. I'm really excited, and anytime I can take an opportunity to talk to people about what we do as forensic nurses, how we help patients, and of course, strangulation, that's one of my babies. I'm always excited to do that. So thank you again for having me. A little bit about me. My name is Andy Greco, or Andrea, you will see here. I'm a registered nurse of 17 years. All emergency room nursing, although the last 9 years I've also been doing forensic nursing, been doing that now full time I've been doing it 9 years, probably only forensic nursing for 5 to 6 years. We'll talk a little bit more about my program later on as we go. I got into this work mainly because in the emergency department, you see people in their worst, you see horrible traumas, horrible illnesses, all of that stuff. And I definitely see victims of violence all the time. But as an emergency department nurse, you just don't have the time to really give these patients what they need. You're there to get emergencies taken care of and get the person out of your department. And I really learned that patients that are affected by violence are an extremely vulnerable population. They're an underserved population, and they deserve our time and attention. As most of you already know, there are a lot of health consequences long-term, both physical and psychological, that we see with patients that have been affected by violence. And so the more we can do up front to help mitigate that, the better. So yeah, so I am really excited to be here with you guys. Please ask questions at any time. I'm very informal. We are going to talk a little bit about forensic nursing and that stuff, and then I promise we will get to strangulation. If you need more about strangulation, it was kind of, I can talk for hours on it, but I know this isn't a medical group. We can certainly always set something up later if we need more detail on that. But all right, so I'm going to turn off my camera here, if I can get that, and we'll get started. Okay. Why is my screen not? Oh, there we go. Okay. All right. So first of all, just a little bit about forensic nursing. Okay, so annually across the globe, there's more than 1 million lives that are lost as a result of either self-inflicted, interpersonal violence, or collective violence. And this trauma that's associated with this violence continues to really affect our society. And it's really Sorry, do I need to start again? I don't know what happened.
Just a second. Yeah, that's better. Go ahead. We had you until starting over again with how many lives are lost.
Okay, so there are about 1 million lives that are lost as a result of all kinds of violence, interpersonal, self-inflicted, and collective violence. The trauma that's associated with this violence continues to plague our society, compelling the victims of these injuries into the hospitals, and they have evidentiary components to their medical care. And so that's one reason why the evolution of forensic nursing has come around. So just a little bit about forensic nursing. The International Association of Forensic Nurses, that's our governing body, describes forensic nursing as the application of forensic science combined with the biological and psychological education of the registered nurse, in the scientific investigation, evidence collection and preservation, analysis, prevention, and treatment of trauma and death-related medical issues. My thing is not advancing. There we go. It's just taking a little bit. So just kind of the history of this. And part of the reason we talk about this is because the overall violence is the leading cause of deaths in people ages 15 to 44. So the leading cause of death from ages 15 to 44 is due to violence. And so it's an epidemic for sure. And the cost of our violence, it equates to billions of US dollars in annual healthcare expenditures. So it's a big deal. So back in 1976, the first sex assault nurse examiner program was established in Memphis, Tennessee, followed shortly there in Minnesota and then in Texas. In 1991, there were 20 SANE programs, once again, that sex assault nurse examiner programs. And typically what it was is you would take a nurse and they would just have a little bit extra training to do. So if they were the emergency room nurse and someone came in that was affected by violence, then that nurse would hand her patients over or his patients over to another nurse. They'd go over, see this patient, and come back. And obviously not a very good game plan. So in 1992, the IFN was formed and Virginia Lynch was the founder of that. She's kind of the guru of forensic nursing. And then in 1995, forensic nursing actually gained our recognition by the American Nurses Association that it was a specialty nursing subset. The Office for Victims of Crime, they are a big proponent of getting SANE programs throughout the country, as they were realizing the benefits of having a trained nurse that could care for victims of violence in clinical settings. In 2009, the American Nurses Association and IFN, they published a scope and standards of practice that we follow as forensic nurses. Now, as of 2016, there are more than 800 sex assault nurse examiner programs, but less than 20% of emergency departments have a SANE program, and that's a problem when you're looking at the amount of people that are experiencing violence, and only 20% of our emergency departments have a qualified, trained, educated forensic nurse or sex assault examiner. That is a problem. There are only a dozen in-house forensic nursing programs throughout the country, and I'll talk about ours in a little bit because we are one of them. In-house meaning that there is a forensic nurse available at all times, versus a lot of programs function by when someone presents to the emergency department or clinic, wherever they're working with either a sex assault or intimate partner violence, strangulation, whatever the assault was, they have to call in the specialty nurse. And that can take, most programs have like an hour callback time. So then your patient is having to wait for this specialty nurse, which we don't want them to do. Education of forensic nurses, obviously they have to be a registered nurse first. And then most nurses will start by doing their sex assault nurse examiner course. You can take a 40-hour didactic course for that. We have here in Colorado, and I'm one of our former trainers on this, we have a 64-hour course that is combined adult, adolescent, and pediatric. It's all online. So registered nurse, or you can also be advanced practice physician or a physician's assistant. They're just called a SAFE, sex assault forensic examiner versus nurse examiner. But so there's a couple different ways to get this initial education, but they have to have at least a 40-hour classroom training and then about 40 hours of clinical training. Let's see. Oh, I already mentioned that. Okay. So a sex assault nurse examiner is a registered nurse who has special education to provide comprehensive care to the sex assault patient. I'm just bringing this up so you guys understand the background of what we do. Most nurses start in this realm, taking care of sex assaulted patients. However, as most of you probably know, a lot of our sex assault patients have a either intimate partner violence associated with it or strangulation associated with it. Hence why we have advanced from just a sex assault nurse examiner into forensic nursing, because so many of our patients have multiple types of assaults. You can see the requirements here. These minimum 2 years of clinical experience in practice, that's going to change based on what program a nurse is going to be hired into. At our facility, we want more than 2 years experience. We work with a lot of autonomy, and we want the nurse or the provider to feel very comfortable practicing on their own. You do not have to have emergency department, experience, ICU experience, although they do tend to help the more acute care experience that you have. We do work autonomously for sex assault patients, especially in our program. We do not have another provider see those patients unless we find a reason that they need to. Otherwise, we will be taking care of that patient, providing all of their care, diagnosis, treatment, and their medical screening. So that's why it's important. We want people that are very confident and competent in their skills before we'll hire someone in. Okay, so now forensic nurse examiner. This is someone, like I said, we've expanded to see basically all patients that have potentially experienced violence or trauma. So now we've expanded from sex assault patients into intimate partner violence patients, elder abuse and neglect, child abuse and neglect, all strangulation patients, physical assault. So anyone that's experiencing some sort of violence or trauma, we can get involved in. Most forensic nurses will practice in a hospital setting, although you can also have clinics that will take care of sex assault patients only. If there are components of other violence, such as strangulation, they typically need to be medically cleared by an advanced provider. So those patients will end up at a hospital. Forensic nurses can go into death investigation. That is not something I'm interested in, but they can work in mental health facilities. They can be legal nurse consultants, helping in court cases. They can obviously work in correctional facilities as well. So just very quickly, you can see what sex assault is, and we're not going to focus on that, but it is the involuntary sexual act in which a person is coerced or physically forced to engage against their will or in a non-consensual sexual touching of a person. It is a form of sexual violence, and it includes rape, which is forced vaginal, anal, or oral penetration. It can also include drug-facilitated sexual assault. That can be alcohol or other drugs. And then you can see here there's multiple different types of sexual assault. Since most sexual assault victims, their injuries, if they even have injuries, are not life-threatening, and the diverse needs of the sexual assault victims, they're just not fully understood by a lot of ED physicians or providers or nurses. So a lot of times these patients that come in after a sexual assault, they're not recognized as needing priority care. And I know most of you are advocates of some sort, or at least you're working with these victims of violence. You do understand the consequences that these patients are facing if they don't get care. So another reason why we like having forensic nurses or sex assault nurse examiners, because we do understand the complexities and the importance of getting these patients medical care and treatment.
So
Intimate
Andy,
partner.
Going back a slide, we had a question. Are all SANEs forensic nurse examiners as well?
No, that's a good question. No. So the majority of, and there's not really like a delineation right now. So the majority of these nurses are going to be sex assault nurse examiners, SANE. So they've taken their basic education on that. They've done preceptorships. They've done clinical training. Then typically what happens in those programs, if they're in a program that is seeing other patients, strangulation, intimate partner violence, that stuff, then they will continue on. We have a lot of courses that we can do on strangulation, advanced forensic nursing. The IFN, that group I was talking about earlier, has a lot of different educational opportunities to expand our practice. So there's not right now a certification for forensic nursing like there is for sex assault nursing. It's just kind of a title that we've expanded to say, hey, we are taking care of all forensic or all victims of violence. It would be important to know if you come across a patient that you think needs medical care for strangulation, intimate partner violence, something like that. I was going to talk about this later, but CASA has a map of where all of the sex assault nurse examiner programs are in the state of Colorado. And so you could also probably call ahead and find out what type of patients, because a lot of our sex assault nurse examiner program, so our program does, we do the education for the state. So a lot of them have had the training on strangulation and intimate partner violence, and we'll see those patients on top of the sex assault patients. So I would say if you can look up where those programs are, and just start asking some questions.
Awesome, thanks so much.
Yep. Okay, intimate partner violence, people might know it as domestic violence, but domestic violence could be anybody in the home, anybody you're living with, roommates, children, things like that. So the new term is intimate partner violence. And this is someone that has been either in a relationship in the past or is currently in a relationship or what they consider intimate. And that's violence, physical, sexual, or psychological harm to a current or former partner. We do see obviously heterosexual couples, but we also see same-sex couples as well. Okay. A couple of the other patients, we see strangulation patients. I told you we see child abuse, elder, and all of that stuff. We're not even going to touch on those for this class. But we do see strangulation. Obviously, we will talk more about what strangulation is. You can see it right here. But we'll go more into detail about strangulation. And then we also will see human trafficking patients, although I will tell you that's a whole nother presentation. Human trafficking is a very complicated situations, and most victims of human trafficking either don't recognize that they are a victim or are not going to come forward for multiple reasons. So that's a very complicated situation. A couple of things. We'll talk about the strangulation here in a little bit more detailed for you, and explain the difference between strangulation and choking, because a lot of people hear the word choking. Okay, what do forensic nurses or sex assault nurses, what do we do, and why is it important? Why am I telling you this? You may be going, I don't care, Andy, why you do this. Well, there's a reason. We, number one, have the training and the education on how to identify risk factors within patients. When someone has experienced a trauma, whether it's real or perceived trauma, that can cause neurobiological changes and psychosocial effects in these patients that have experienced this or perceived this fear, this trauma. Okay, so when that happens, their behaviors may change. And so acute stress symptoms can arise after an assault, regardless of what the assault is. And what this can look like, it looks like a lack of focus and attention from our patients. The response can mimic symptoms of other physical injuries, such as an acute brain injury. And so people, a lot of times they'll think that, or they may have blunting of emotions, or their affects really flat. So people think that they're being uncooperative, that they just don't want to talk to you. They don't want to engage. Sometimes it goes the other way. They're just being dramatic, or they're drunk. We'll talk a little bit more about that. And so what we can do is we go in and start, we have that training and that understanding of, wait a minute, this may be related to trauma, these behaviors, and I need to look more into this versus just brushing this patient off. So that's one thing that we do. We have specialty assessments. I'll go through that with you in a little bit. Injury documentation, of course, we can do that through diagrams. And I'll show you what our diagram looks like, where we're using obviously our words. That's very detailed, very objective documentation that your other ED staff or clinical staff are not going to be doing. They don't have the time. So we certainly can document it in their medical record, but we can also use photography if the patient is giving us permission to. And that's obviously a benefit. Once people can see what we're documenting, that's very helpful. So we can certainly do that. Evidence collection, I'll touch on a little bit later. And then resources and safety planning, of course. It's not our job to make sure that person is in a safe place, but we certainly, we can't force a patient to leave an abuser. We can't force the police to do stuff, but we certainly can talk about some safety planning with them. We do definitely connect them with our community advocates. If they're wanting to work with law enforcement, we'll connect them with law enforcement advocates, and then any other kind of resources that we can, whether it's alcohol, drug, shelters, whatever we can. We're going to take the time to try to help facilitate that planning for them. A couple more things. Obviously, I just said it, we bring in advocates, and we're very lucky here in Colorado Springs is where I am. We have Tessa as our local advocacy group, and they're just fabulous. So we will definitely connect with them. Follow-up would be if they're needing follow-up medical care, if it's a sex assault and they're needing follow-up sexually transmitted infection testing, they need follow-up with medications, whatever that is, strangulation. If they don't have a doctor, we're going to make sure that we're connecting them with people for a later time. If these people are wanting law enforcement involved, we'll talk a little bit about, because they don't have to have law enforcement involved, but if they want to, we will certainly help facilitate that as well. The multidisciplinary collaboration is pretty obvious. That is with our other medical staff, medical professionals. We do see patients that get admitted to the hospital. So that's us working with their inpatient staff. And then, you know, the advocacy is law enforcement, anybody else that they're needing help with. We're going to try to assist with that. We do provide expert testimony. I'm going to tell you, if you go into emergency department, you know, the emergency department physicians, PAs, nurse practitioners, they don't want to get subpoenaed. They don't want to have anything to do with our patients. Well, we take care of that. We get the subpoenas and we will testify in court, and we are trained on that. I think I've done about 50 what am I trying to say? Expert witness testimonies. So we are trained on that. And then obviously the evidence collection that we'll touch on a little bit. Okay, I want to mention this, and I know I'm probably preaching to the choir, and I apologize for that, but I do think it's really important that we always talk about trauma-informed care. One of the reasons that I love talking about this work is because anybody that's gone through the training to be a sex assault nurse examiner or a forensic nurse examiner has had training on trauma-informed care. Not a lot of other medical professionals have, although that is now becoming, I think they're starting to integrate that more into nursing programs, medical programs, things like that. I'm currently getting my nurse practitioner, and it is incorporated a little bit in there. But it is extremely important that we understand this. So it's defined by the Substance Abuse and Mental Health Services Administration. Trauma is an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. And what we know is with trauma-informed care is that people may have experienced past traumas or have other traumas or stories in their life that have affected them. And then they come in with this background of this trauma, and that can affect how they're dealing with this current trauma. And so we need to understand that trauma is very widespread. The impact on each individual is different. It's not a black and white picture. So we want to make sure that we understand that when we're talking to these patients, understand how it's affecting them, their families, people around them. And then we are going to apply this knowledge and put this into our work ethic when we're talking to our patients, and understand, I get this, like I said, I've done ER nursing for a long time, and I hate to say it, I'm sure I did this too, but people are like, oh my gosh, they're just drug seeking, or oh my gosh, they're frequent flyers, or they always have a headache and we can't ever find what's wrong with them. It's these psychosomatic pains, abdominal pains. And when you actually take the time to sit down and talk to these people, it's real interesting, the traumas they've had in their life that are now coming out in how they're acting now. These headaches that are chronic, these abdominal pains that are chronic, but we can never find a real pathophysiology of what's going on. They're not making it up. It's probably an effect from past traumas. And of course, we want to prevent re-traumatizing the patient. So that's something that we will learn. We know when we use trauma-informed care that the patient outcome is better. There's multiple studies on that. Some of the things here, we really want to focus on safety. These patients are coming in, they've had something bad happen to them. They're scared, they're angry, they're upset, they're emotionally flat. And there's so many different ways these patients will present. So we want to make sure they, number one, feel safe in all aspects. I know in our facility, we don't have these patients waiting out in the general waiting room. Once we find out someone presents for some sort of violence, our sex assault patients are immediately brought back to a private waiting area. And with our other patients of violence that do have to see a medical provider, we will try to get them at least out of the main waiting room if we can't get them back right away. Just a little push. Our program is moving forward with a forensic center of excellence. It's slated to be next summer. So basically it's going to be a unit within our emergency department unit with its own beds, own waiting room, nurses station, all that. So these patients can get out of the main emergency department area and feel a little bit more safe. Other ways to make this person feel safe is just be transparent. I will tell people, I will be honest with them if I do have to call the police or not, if I'm involving child protective services. You know, I'm very honest about what I do have to report, what I don't have to report, things like that. I want them to trust me. If they don't trust me, I'm not going to be able to help them. We give them choices. We want to provide autonomy, so we will go through what their choices are, and we do not make our patients do anything that they don't want to do. They get to make the decisions. We offer them things and then they can make those decisions. We'll obviously work in collaboration with them and try to meet the person where they are and give back some power to this person has had power and control taken away from them. So we want to try to give that back to them. All right. And I'll tell you guys, it starts a lot with whomever this victim of violence comes in contact first, whether it's a friend, whether it's an advocate, whether it's a police officer, whether it's a medical professional. That first interaction of someone saying, I'm sorry this happened to you, I believe you, you don't deserve this, man, it makes a huge difference when I see patients coming in that have had a good experience from one of the first people that they worked with. It just, the interaction is so much better. So just keep that in mind. Obviously, we know the long-term consequences of violence. It is detrimental. I'm not going to go into all the studies or all the stats of that, but the long-term health consequences are just a lot. But one of the psychological impacts that we can help prevent, hopefully, to help improve the patient outcomes is when we make these patients feel supported, believed, safe, respected, in control, the outcome is better, regardless of prosecution results. We know a lot of these cases, especially sex assault cases, do not even get to the courtroom. Strangulation, I do think we see more. I've done more strangulation testimony than any kind of testimony. They go a little bit more, but you know, you never know what's going to happen in a courtroom. I just had that experience last week. Patient, or the man was found, the defendant was found not guilty on all charges. There was a lot of injuries, a lot of whatever, but the judge told the prosecution the jury didn't like the victim on the stand, thought her attitude was bad, so they didn't believe her. And that's why they found him not guilty. So you can't control that. Medical benefits, obviously, so you're seeing this is more for sexual assaults. We can prevent pregnancies and sexually transmitted infection by offering medications prophylactically to prevent. But with our other patients, our strangulation patients, intimate partner violence patients, you know, by us helping in this trauma-informed set, it may reduce some of the physiological or physical complications later, these headaches, abdominal pains, other pains that they may be experiencing after assault. So that's our goal, is to help decrease those impacts. We do know in the criminal justice, we do not do our work for the courtroom for prosecution rates. That is not our job. We are medical, and we make sure we stay in that lane, and we make that very clear to everyone we work with. We are medical. However, we do know that when people have seen an educated, trained, SANE or F&E, evidence collection is better, photography is better, the overall documentation is better, and that can increase results in the criminal justice world. Like I said, that's not why we do this work, but there are studies showing now that another reason why it's important to get these people where there is someone who's trained. Real quick, our team, just so you know us, my team is a 24/7 in-house program at Memorial Central UC Health in Colorado Springs. So we are there, at least one of us, there's supposed to be two of us, but nursing shortages are real right now. But at least one of us 24/7 at that hospital. The number you see below is that number directly to the forensic nurse. 719 is area code. I should have added that. I apologize. So if you ever have any questions and you don't know who to call, you can call the forensic nurse. There is somebody there at all times. We do work at our North Campus as much as we can right now. That's looking at about 36 hours a week, although as we've just hired 2 new nurses, hopefully we'll be able to get up there more. One of our newest projects is I work over at our Child Advocacy Center here in town. So we have advocates and law enforcement and DHS and therapists, and then we're the medical side for children that are disclosing sexual abuse or violence. So we're also over there. But don't ever hesitate if you have any questions to contact us. We saw over 2,600 patients last year there were about 14 or 15 of us. So we are a busy place. Hence why we're always there. And if we don't know the answer for you, we'll find someone who does. We've got the resources to, or help find a program near you. If you're with someone who's needing medical care, we have access to find where programs are for you. Just real quick, you guys, so you know, I think this is important. If you're dealing with a patient that, or you would call them a victim, that comes to you, that's reporting violence, just know, and you may already know this, but obviously they can involve law enforcement or they don't have to. Now, the caveat is they have to be 18 to 69 years old, that they then have the choice. They don't have to involve law enforcement. And we get a lot of people that don't want to come for medical care because they think we have to call the police. We don't. I will explain on the next slide the reasons we do have to call the police. And once again, myself, my teammates, I can't speak for every forensic nurse, but should be letting them know the reasons up front why we would be calling law enforcement or not, because we want to be transparent. One of the reasons, and I'm sure you guys know this, that, you know, a couple of reasons why intimate partner violence is not a mandatory report is there may be safety concerns that cannot be addressed at this time, even with law enforcement involved, and it can really put the patient at risk if we were to contact the police. In fact, death rates, homicides go up significantly when a perpetrator finds out what's going on. So that there's that reason. We don't want our patients to not seek medical care because they think that we have to call the police. We want them seeking medical care, and then we will handle that reporting with our patients alone. And then, of course, there's multiple other factors of why patients don't leave an abusive relationship. And it's not for us to judge. It's just for us to meet them where they are and provide as many resources as possible. Here are those mandatory reportings. 70 and older in Colorado is an at-risk adult. So we would have to report to that. And if they're under 18, they're considered a child. So we would have to report that, any violence there. Otherwise, anybody else, if there's serious bodily injury, that is a legal document that we look at, basically fractures, burns of the 2nd or 3rd degree, a risk for death, a risk for a serious permanent disfigurement, a risk of loss of a body organ's function. Those are serious bodily injuries. Those we do have to report. If they're assaulted with a deadly weapon, a gun, a knife, a bat, I mean, whatever we deem as a deadly weapon, we would have to report that. And of course, if children are present during the assault, this is always complicated, even if they were not hurt. We will be at least reporting to Child Protective Services or DHS, because we know the dangers of a child living in a home where there is violence. And that can be hard explaining that to a patient. But I will be transparent and let them know that. Okay, that's why you're really here, right? You want to talk about strangulation. Are there any questions right now that I can answer before we move on?
Actually, this is Kirsten. I've got one. When you talk about those mandatory reporting standards on intimate partner violence, is that a standard that was set? What am I trying to say? Is that a standard per your program and protocols?
No, that's a Colorado statute.
Law?
That's a Colorado law. I can't remember the exact time. Someone else may know the exact year that law came in. It first changed with sex assaults, because there's 3 reporting options for sex assaults. And then the not mandatory reporting for intimate partner violence and physical assault. I can't remember. It's been around for quite a few years now, though. 5, 6, 7, 8, 10 years, something like that. I don't know the exact, but that is statewide. And a lot of people don't know that. So if you're coming across someone at you know, they think it has to be reported, I mean, you can certainly call us because all the people on my team, we will know the answer to that, and what is reported, like what you do have to report and what you don't have to report.
Thank you.
And you know, here's one thing: if you make a report by accident, first of all, if you're not medical, you're not gonna get in trouble for it. But here's the deal. I've had that happen where a friend or somebody calls the police, or they come from another hospital and they've already called the police. Well, I just interrupt them. I just stop the police and say, I'm really sorry. The patient does not want to talk to you at this time. And most officers, I cannot speak for all programs, but most of the officer agencies, law enforcement we work with, they understand that, and they may give a card and just say, well, if they change their mind, have them call us.
Thank you, Lisa Batten from Aurora. It looks like that change was in 2017 and she's linked for us. And then we've got a question. Is it standard practice to test the victim's blood alcohol content in a SANE exam?
In a sex assault exam? Absolutely not. No, that is not a standard of practice. And we follow the Colorado Medical Forensic Exam, Sex Assault Evidence Collection, as well as there's some national guidelines. No, what we do is we base it on our clinical judgment. You don't routinely check other patients on their alcohol level. And so we don't want to treat them different than other patients. The reason we would check is only if their mentation was really altered, or they're slurring their words and we don't know why, then we may want to check to make sure that, but that's going to be a medical thing before I'm seeing them. Otherwise, I am going to make my clinical judgment of whether this person, can they walk without stumbling? Are they not slurring their words? Are they making eye contact with me? Things like that to make my clinical judgment. But no, we do not test we don't test other patients for alcohol without a true medical reason. So we wouldn't do it for these patients.
Awesome, thank you.
Anybody else? Are we good? Okay, let's talk a little bit more about strangulation. A couple things, you guys. It is so much more prevalent than we think. When I started as a forensic nurse 9 years ago, I felt like we saw strangulation and intimate partner violence relationships at, they've been in this abusive relationship for a few years, and now it's becoming strangulation. We are now seeing strangulation as the first assault. And we're seeing it so much. We see it with kids, we see it with women, we see it with men. So very, very prevalent. There is potential long-term impacts, both physiological and psychological, and it can happen in any context. So we're going to talk more about this. And I have to watch my time because I get very fired up with strangulation. So I have to be very careful and honor your time. Okay, so a couple of things. Strangulation is a form of asphyxia, which is lack of oxygen, characterized by closure of the blood vessels and air passages of the neck as a result of external pressure on the neck. And that's the key, external pressure. A couple different ways here. Hanging would be self-hanging. Ligatures by somebody using a rope, a towel, a cord, something like that. Manual would be hands. Positional, you're not going to see that typically in adult. That's more, you have a baby or an elderly person that can't move well, and their body slumps over and they don't have the strength to lift up to be able to breathe again. That's not something that we're going to see. We really focus on the ligature and the manual strangulation. So we're going to go into these in a little bit more detail. So once again, it is caused by external force to the neck. And what it does is it is disrupting the blood flow in our vessels from our heart and lungs up to our brain, or it can affect the airflow from our lungs directly through the trachea. The difference here with choking, you will hear people say, I was choked. You hear that a lot. You'll even hear medical professionals say it. That's actually not the right term. Choking is the internal blockage of the airway from like a foreign object, right? So choking is internal, strangulation is external. I will meet my patient where they are. If they're using the word choke, I will use that with them. But when I'm talking to other medical professionals or in the court or with law enforcement, I will use the word strangulation because that is the correct strangulation. A couple other terms you may hear: suffocation, that's blocking respiration. So occasionally, I shouldn't say occasionally, excuse me, at times people will cover the patient's face, their mouth or their nose with their hand or a pillow or something like that. That would be suffocation. They can't get any air in. Asphyxia is a lack of oxygen to the brain. Strangulation is really unique injury because in general, the mechanism of injury is occlusion of the blood vessels of the neck from that external pressure. And that can result in that significant hypoxia, loss of oxygen to the brain. That can cause a loss of consciousness and potential death. We'll talk a little bit more, don't worry. I'm just going through these. I want to go through the anatomy. Obviously, there are a ton of structures here. You don't need to know them. There are 3 structures that are really important to us when we're taking care of patients, the living patients of strangulation. I'm not talking about patients that have been killed by or died from strangulation. There may be some other findings there. What I'm really concerned about are carotid arteries. So that's going to be your red area in this picture, your jugular veins, especially your external jugular veins. There's a big blue one there that you're seeing in the middle of the picture. And then you can't see it here, but the trachea is at the front of the neck, the anterior of the neck, and that's going to be your airway. Okay, so those are what we are really going to focus on. So let me just explain it here while you can see this. So in that blue, big blue vein there, what happens is that is bringing unoxygenated, deoxygenated blood from the brain back down to the heart and lungs so it can get oxygen again. It is very superficial, as you can see there. It's under, some of our neck muscles and tissue, which is going to be different on every single person. Very superficial. We put IVs in those veins when we can't get one peripherally on somebody. Does not take a lot of force to occlude that. What happens if that gets occluded? If I squeeze that, especially on both sides, the blood can't come back down from my brain. So it sits up on my brain, starts to damage the brain cells, causes an increase in pressure, and ultimately can cause someone to lose consciousness and eventually death if that doesn't get resolved. Okay. The big red one's tucked in there, that's the carotid artery. Okay. Carotid artery is stronger. It's more protected. As you can see, it's behind that vein more. It's going to take more pressure to occlude it, although it still doesn't take a lot, but it does take more. That the carotid artery is bringing that oxygenated blood from the heart, from the lung and heart up to the brain. Okay, so that's bringing us the oxygen. If that gets occluded, what happens is now I can't get oxygenated blood to my brain. Well, if I don't have oxygen to my brain, right, eventually my brain cells are going to start to die. I'm going to start to lose consciousness. My organs are going to shut down, and it can lead to a death. Okay. There's no exact science. There's numbers between 4 or 5 minutes, actually between 3 and 5 minutes. If you have the perfect world of strangulation where all of these vessels are occluded completely, they can die within 3 to 5 minutes is brain death. Okay. The problem is most strangulations, well, it's actually a good thing, are not perfect, right? Not all of the vessels are going to be completely occluded. So there's a lot of different variables. The other one, the front there, if you look at the right side of the screen, little bump, that would be, your voice box there, your larynx. So then you go down into your trachea, that's where your air. So you're breathing in, the oxygen, the air from the outside world and taking it into your lungs. So if that gets occluded, and that's a lot stronger, that's a lot of rings of cartilage. If that's a lot stronger, so it takes a lot more pressure to completely occlude that. So typically what we are looking at is a vessel problem. Either the blood cannot come back down from the brain, or we can't get the oxygenated blood up to the brain. So that's the nitty gritty. Okay. Cranial nerves, I'm not going to go into this in detail. There are 12 pairs of cranial nerves, and they will be affected or can be affected if we are having hypoxia or loss of oxygen to our brain. So we do a real thorough cranial nerve assessment. Just to make sure. It's really hard on those because someone may have what we consider a deficit of the cranial nerve, but I wouldn't really know if it's a deficit unless I was able to see them at a later time, and we don't typically do that, but we will do a full cranial nerve assessment with these patients as well. Here is the thing. So we just talked about, so strangulation, right? If someone's putting pressure on the neck, and they occlude those veins only, the jugular veins, okay? Well, my blood can't come back down, but blood's pumping up there. So the pressure in my brain's growing, right? And that's ultimately going to cause damage. If I'm occluded, those are open, the veins are open, so the blood can come down, but my carotid arteries are occluded and I can't get the blood up there. I don't get oxygen to my brain, eventually, brain cell death and eventually death to the person, okay? And obviously if I can't breathe in, if I can't breathe, then I'm not going to be able to get oxygen into my lungs that can then oxygenate my blood. So that's how that works. Well, here's the thing. It is really difficult when we're talking about strangulation. You know, why do people have no injuries? How come I can't see all this bruising? How come I can't see this petechiae, which I'll show you what that is later? Subconjunctival hemorrhages. Why can't I see that if they were strangled? Well, there's multiple variables. Okay. So first of all, when someone's being strangled, where exactly are they being strangled? Is it directly over the vein? Is it directly over the carotid artery? Is it over the airway only? Is it only over, you know, really high muscular area? It really depends. Where is that location of that pressure? How much pressure is being applied? Is it a, you know, it's this, you know, out of a 10, 10 being the worst, you know, 2, you know, I'm only barely applying any pressure, right? Versus I'm putting all of my weight, all my strength, right? So that's going to affect how long is that pressure being applied? Is it 1 second? Is it 5 minutes, right? And so now you're looking at all of this together. And then the surface area is a big one. So if you think about a ligature, if you take a cord or a rope, and I know that sounds horrible, and put that around somebody's neck and pull hard, you are more likely to see a visible injury where that ligature was, because all of the pressure is in one little area. It's only in the area of that small cord. So all the pressure is focused in that area. We tend to see more visible injury on the neck from that, versus take a chokehold, the old carotid restraints, the sleeper hold. Now you take the whole inside of a forearm and the upper arm, and now it's wrapped around a patient's neck. So all of that force is being distributed, right? Excuse me, there, throughout the neck. So you may not see any visible injury, right? What if it's a slow, steady, you know, long strangulation? I may not be seeing visible injury. Okay. So we have to take all those things into the factors when we're looking at someone that is strangled. Also skin color, the health of the patient, the medications, the size. I mean, there's multiple different things that we have to look at when we're evaluating someone with strangulation. So what else can happen? So aside from death, okay, so you can have anoxia, meaning no oxygen to the brain, and that can ultimately cause death, right? Our brain is controlling everything. One of the most dangerous consequences can be injury to those blood vessels, the carotid arteries especially. And if we damage that, and I'm going to tell you, it is not common, okay? It is not common, but if it's missed, it's a big problem. If there's damage to that vessel, so say there's a little cut, okay, a little laceration, it would probably be more than a cut, in that vessel, in that carotid artery, and it starts to bleed, and then it clots because your body clots it. Well, then what happens? I can have a stroke, right? That clot will go into my brain, causes a stroke. So that's one of the concerns we look at when we're looking at someone who's been strangled. They can also have permanent neurologic damage. Once again, those injuries to those vessels, those long-term like that, that's not common. What we go through next is a lot more common, but it's something we have to think about. And the point with strangulation is maybe not at the time, right? They didn't die, otherwise they wouldn't be with me. That would be homicide. But the risk is, had this person not let go of their neck with whatever they're using, that blood flow won't return, that oxygen won't return, and we will end up with death eventually. And that's the concern, okay? You can have some delayed, there's a little literature about it of someone having an injury to a vessel and we didn't catch it. CTAs are not very common. That's a carotid angiogram where you're looking at the carotid artery. If we were to miss that, obviously there's a potential of someone having a stroke later. And then there's some other delayed complications that could happen. I'll touch on it when we get to these symptoms. So we do worry not only about the patient sitting right in front of us, but we do want to talk to them about things to look for in the next few days, and then, you know, when to return to emergency department. Okay, signs and symptoms. So here, I do not expect any of you guys to remember these, to know all of these. If someone comes to you though, I would love for you to there's a couple that I want you to kind of take away with you, that if you were to recognize with someone who comes to you talking about maybe being assaulted by a partner or a sex assault, they don't mention strangulation, these may trigger you to start asking some more questions. So we'll highlight a few of these. Also, please remember, a patient doesn't have to have these. It doesn't mean they weren't strangled, okay? But these are signs and symptoms that they may experience. Well, let me touch on this. I didn't say this. So during a strangulation, we will ask them, did you lose consciousness? or did you lose control of your bowel or bladder? The reason we ask that is those are serious side effects. Those are serious symptoms. If someone loses consciousness, to me, that is an indication, like I talked to you about, that we don't have enough oxygen to our brain, whether that's because the blood is stuck up in our brain, causing an increase in pressure, or we can't get the blood up to the brain or enough oxygen to the brain, will become hypoxic, so low in oxygen, and eventually anoxic, no oxygen. Well, once we get to the point where we don't have enough oxygen, or our brain cells are starting to, be compromised, we can lose consciousness. So that is a physiological indication to me that this person was in a serious state. They lost consciousness due to the strangulation. I can't prove it because I wasn't there, but I take what the patient's telling me happened. So that's important. The loss of bowel or bladder is also a neurologic problem. When we have brain cell damage or no oxygen to our brain, we will lose that voluntary control of sphincters of your bladder and your rectal sphincter, and so they can lose control of that bowel and bladder. That is another indication to me that this was a very serious strangulation. So those are important. We do ask. And then I also just ask, when this was happening to you, anything else that you experienced? That's when patients will tell me, I thought I was going to die. The look in his eyes was horrible. I couldn't breathe. I thought of my children, and I will write those things down. Those are all very important to help us understand what the patient was experiencing and how scary it is. This person is right in front of them. They can look them right in the eye when this is happening. So I do want the patient to have that opportunity to share with me what they were experiencing. Okay, after that, things that they may experience after a strangulation: coughing, difficulty breathing, difficulty swallowing, painful swallowing, headache, lightheadedness, neck pain, neck swelling. That's really hard to know if your neck is swollen. Nose pain, nausea, vomiting. Voice changes, we'll ask them if they say yes, they've experienced voice changes. We'll have them describe that, to us, since we don't know this person. So what's different with your voice? If they have someone with them, sometimes they corroborate that. Vision changes. Okay, what do you mean by vision changes? People will talk about being blurry, things like that. Voice changes, typically hoarse, raspy, or lower is what most people will tell us when they're experiencing a voice change. If I feel like their voice, I just had this in a case, the patient sounded hoarse to me. Now, I don't know what they normally sound like, but their voice sounded like a smoker voice. So I ask them, is this your normal voice? No. Do you smoke cigarettes? No. And so then I will note that I heard a hoarse voice. Could I be challenged later where you don't know what they normally sound like? Correct. No, absolutely. But it was enough of a voice that I'm listening to that sounded raspy or whatever. And then I ask the patient, is this your normal? Restless combativeness, that's the patient who can't sit still. That's the patient people think are being jerks, that are being drunk. No, it could mean that they've had a little bit of loss of oxygen to their brain, causing them to be restless or combative. They can also be scared, right? Uncontrolled shaking, memory loss, weakness or tingling in the extremities. The paralysis isn't something they're going to know. That's something I'm going to be checking for. And that would be extreme if we had paralysis. That's someone that's having a neurologic issue, definitely needs to have some further imaging done if we see that. So for you, what I want you to remember is, these are subjective things I'm asking my patient. What did you experience? What are you experiencing now? Or you experienced after the strangulation, now it's gone, right? Those are all subjective. That's what the patient's telling me happened, okay? There are some objective things that we can look for too. We'll go over a couple of the injuries that you can see, obviously visible injuries, but a couple other things. Is your patient having trouble swallowing? Did you give them water, or they have a drink, they have a soda or whatever it is, and you see them grimacing when they're swallowing, or, closing their eyes when they're swallowing? Note that, okay? If they're clearing their throat, that a lot, that could be part of a nerve thing, a laryngeal nerve. It could be part of the larynx itself, having some trauma to the larynx. That's your voice box, right? So you can pay attention to that. And I have seen people do that. You may watch them coughing, and it's not that, doesn't have to be that deep cough from the lung. The coughing that we start to worry about, obviously it can be directly from like the larynx being bothered, that voice box, but it can also be if they vomited during or right after this assault. What if they took a breath in, right? And then they aspirate some of that fluid, that emesis gets into the lungs, they can eventually develop pneumonia. Potentially, that's something that we would think about, but they may be coughing because of that. Are they rubbing or holding their neck? You see them moving their neck around, right? They're like, you look, it's like they're trying to stretch it out. They're trying to rub it out. It's bothering them. Or I'll see patients just kind of, like grab the front of their neck and then kind of grimace as they swallow. Just take note of that. And then what does their voice sound like? And like I said, you don't know what their normal voice sounds like, but you're looking and you're like, oh my gosh, sounds like someone who's been screaming. Okay, ask them, is this your normal voice? And you can definitely, if you are noticing some of these things, and then some of the objective injuries, I'll show you a couple pictures here in a moment. I do encourage you to try to get this patient medical care, especially if it's within the first 72 hours, 36 for sure, but even that 3 days, if they haven't had any medical care and they're talking about being strangled, they'll probably use the word choked to you. If they say, I was choked out, or you ask them, did you lose consciousness? Did you pee yourself? Did you poop yourself? I'll tell you, patients get very embarrassed and they don't want to answer that question sometimes. Sometimes they'll tell us as the medical provider, but any loss of consciousness, loss of bowel or bladder, please encourage them to get medical care. Or you're seeing visible injuries, or you're watching them struggling to breathe, struggling to swallow, things like that. Just really encourage them to get medical care so we can get them fully evaluated. Okay. So when they come to see us, when a patient comes to see us, what we'll do is we will do a full strangulation assessment. Okay. So if a patient comes to where a forensic nurse, every program is going to be a little different. I know UC Health in Denver, the Anschutz campus, they're there 24/7, but I know a lot of your bigger hospitals, especially, will have people that can do all of this. UC Health, we have the same electronic medical records. So any of the UC Health facilities will have this, what I'm showing you, in our strangulation assessment. But a patient comes in, what we do is we talk to the patient first, introduce ourselves, let them know that we're sorry this happened to them. It's not your fault. Thank you for coming. A lot of people don't come forward, so thank you. We try to give them back that reassurance, that power. And then we can explain all the options. One is gathering the history from the patient of what happened. We want to know in their words what happened. And then we will ask clarifying questions after if need be. Okay. When someone has been strangled, what we will then offer to do is a full physical assessment. And these are just different diagrams that we'll utilize to help diagram where the injuries are and what they are. It gives a better visual later on, but we want to do a full physical assessment. Okay. I'm not just looking at the neck on this person. I want to look at their entire body, because if someone is sexually assaulted or somebody is strangled, that is a very distracting, scary assault. And people don't always recognize other injuries. They're very distracted about being strangled, or they're very distracted about this sex assault. They just don't even pay attention to anything else. So I want to make sure that I'm looking everywhere that patient will allow me. That's looking in the eyes, ears, nose, throat. I'm pulling lips down to look in the inside of lips. I'm pulling eyelids up to look for injuries. I'll show you a picture of what we look for in the eye. Anywhere that patient will allow me to look, I'm going to look to make sure that we're not missing anything medically. And then if they are wanting photos taken, that we're not missing that stuff. If they're wanting evidence collected, then I know where I'm collecting evidence from. So very, very thorough physical assessments. And then what happens is we'll do a strangulation assessment where I'm asking what you just saw, all of those, how long, how often were you strangled, how many times, in what manner, one hand, two hands, from the front, from behind, chokehold, ligature. Did you have a necklace on? Because that can function as a ligature. It can also be an evidentiary component. What did they feel during the strangulation? How long did it feel? The pressure, the pain. We go through all of those things. And then since the strangulation, have you experienced any of the above? And then we'll do this physical assessment. I should have put it in a PowerPoint. I'm sorry, but let me tell you about the evidence as we move on to these visible injuries. I'm going to just show you this picture. But so when someone has been, I'll talk about it in a moment. When someone has been strangled, we can collect DNA evidence from that person. So if they were strangled with the hand, two hands, even maybe a forearm, as long as there wasn't a shirt on, we can offer to do swabs of their neck. It's 2 cotton swabs, slightly dampened with some sterile water, all over their neck. And what we're looking for is touch DNA. That is not something that I will have an answer to, but that can be sent to a crime lab. And if they choose to analyze it, they're looking for touch DNA on this person. Okay. We then also have to get the patient's DNA, that is the control DNA. So we swab the inside of their cheeks. It's called buccal or buccal swabs. So we can do that. The other thing is, as I'm looking through a patient, unfortunately, recently we're seeing a lot of people being bit by others. Adults are biting other adults. I have no idea what's happening, but we've seen a lot of human bites. We can certainly also swab those areas for evidentiary purposes if the patient is wanting us to. Remember, this is all the patient's choice. Do they want an exam? Do they want to talk to us? Do they want photos? Do they want evidence collection? All of that. And some choose to just do some of it. Some do all of it. Some do none of it. It really is their choice. But ultimately, we are trying to provide as much medical care as possible for these patients. Petechiae. So these are some visible injuries. Everybody wants to know what petechiae is, and everybody gets excited about petechiae. Petechiae is it's just burst capillaries, to put it very simply. It's when there's pressure built up in the form of strangulation. So anywhere from the pressure up, okay, where the pressure is applied and up. So think about it. When those jugular veins get occluded, that blood gets stuck right up in the brain, and our intracranial pressure builds up, and it's building and building. So these little capillaries burst, and you see these little red and purple dots. They're about 1 to 3 millimeters in size. Okay, that's how you know it's petechia. They won't be bigger than that. If they're bigger than that, it's called something else. They can be red, they can be purple. They can be really hard to see with people with acne or with freckles or people with dark skin. So we have to look very, very closely. On the left is the eyelid. You can see it up into the eyebrow. You can see it actually down below the eye. Those are all symptoms of petechiae. Now, you can get petechiae from multiple reasons, okay? Other medical conditions, sneezing, coughing. Now, it takes quite a bit of force, when someone's coughing, lifting really, really heavy weights, that because that pressure is building up, okay? So there are other reasons, but for us, we're looking at the strangulation, the pressure being built up, and those blood vessels having to pop. Okay. Under that eye, I would pull that eyelid up. I may have those dots in the eye or under the eyelid. So I'm going to be looking there. I'm going to look anywhere from the point of pressure up. So in the eardrum, sometimes you can see petechiae. You can see it all over the face, in the head. You can see it in the mouth. You can see it in the roof of the mouth. Now, if you don't see it, that doesn't mean a strangulation didn't happen. Okay, you absolutely do not need petechiae to say that there was a strangulation. And I've seen hundreds and hundreds of strangulation patients, and a lot of them do not have any visible symptoms, let alone petechiae. The one on the right there, that's just petechiae in the neck. You can also see a ligature mark and a regular, like a round bruise sitting right in front of us. But those are examples of petechiae. The next one is something you can see in the eye called the subconjunctival hemorrhage. Same thing. When we're looking at strangulation, we're looking at the blood flow being compromised and pressure being built up, and it can cause blood vessels under the conjunctiva of the eye. That's the clear coating of the eye. It's also can be clear coating of the eyelids. So those vessels break and it starts to bleed, and the blood just gets trapped in there. Now it looks horrifying. Okay. It actually doesn't hurt the patient. They're not feeling this. Okay. It will eventually go away. I don't have an exact time frame for you, but it is something that we will look for because it could be caused by strangulation. It can be caused by other things as well, such as heavy weightlifting, horrible coughing, vomiting, not sneezing. I said sneezing earlier. You're not going to get it probably from sneezing, but vomiting, coughing. But those are pretty, that's when that person is really, really sick, and, takes a lot of force for that. So, but you can see it for other reasons. You also do not need to see subconjunctival hemorrhage for strangulation to have occurred, but it is something that we look for. What we do as forensic nurses, I don't just look in your eyes with a flashlight. I'm pulling your eyelids down, I'm pulling your eyelids up, and I'm having you look side to side because sometimes they're little and you can't see them without them moving their eyes around. But that is something that could be a symptom from strangulation. And if the patient's telling you they were strangled and they have that, well, it fits right along with what they just told us happened. So a couple of other
sorry, we've got a question. Is there a
Yeah.
time frame that is best for the collection of touch DNA?
Yes. So in Colorado, this is Colorado specific. Okay. It has been changed to 5 days. So 120 hours is what most programs in Colorado will, because we all follow very similar guidelines. Touch DNA, they actually can get quite a bit of touch DNA. I'll tell you the problem with touch DNA, our science is so good now. If this is an intimate partner, they're going to say, well, of course my DNA is on them. I live with them, or I share a bed with them, or I gave them a hug earlier. Right. So it's not that it's always used, but it's not going to hurt the patient to do it either. But yeah, 120 hours is the standard for any evidence collection. Now, I will tell you, there are times, and that's regardless of whether they've showered, taken a bath, changed clothes, anything like that. Okay, we can still do it. I will tell you, there are times in some situations that's not a hard and fast rule. I have had patients that maybe have been held, been assaulted over a few days, been held for a while. They have not had, they come in at 6 days later, 140 hours later. They have not had any bath, shower, anything like that. They really want evidence collected. I'll collect it. That's fine. It's up to the crime lab whether they're going to actually test it or not. But so there are circumstances you can do that. But 5 days is your standard. Good question. Get my screen off. Okay. We're almost done. These are some more visible injuries you can see. So these are bruises and abrasions on the front of this neck. That looks very much like a ligature mark to me at the front of this neck on this patient. I don't recall, what the history on this patient is, but just because it's linear, right? It's long and linear. So it doesn't mean there was a ligature, but it certainly would fit if they're talking about a ligature being used, a towel, a rope, something like that. You just see this real distinct line of bruising. This patient has a lot of visible injury on the neck. Well, I want you to please remember, a lot of our patients have no injury, or it's so minute that it's really, really difficult to see. Okay, so please keep this in mind. But bruises are caused from blunt force trauma, and it's causing the break of the vessels underneath. The blood starts to leak out, gets trapped in the surrounding tissue. Abrasions or scratches, they're essentially the same thing. That's where there's going to be some kind of lifting of the skin, break in the skin. A bruise doesn't have a break in the skin. An abrasion does. You can actually see the skin gone. That can be caused by the patient, the victim's own fingernails. Think about it. If someone has something on your neck, what are you trying to do? You're trying to get it off your neck. So you may be scratching yourself. Okay. And that's fine. I can't tell if it's the patient's fingernails or somebody else's fingernails. Okay. I'm just going to document what I see and document what the patient tells me. Another area that we look is right under the chin or the jawline, because they might have been grabbed at the same time or smothered. Or think about it again. Someone puts you in a chokehold. What do? You drop your chin, right? You're trying to protect your neck. And so there could be bruising in there as well. So we will look all over, back behind the ears, all over this patient's neck, but you can certainly see these type of injuries. You will hear people talk about fingernail marks. I would be very hesitant to say that. It may be consistent with fingernail, and we'll document it as like moon-shaped or curvilinear is a better, we'll measure it, 1 centimeter curvilinear abrasion. I wasn't there, so I can't say it's a fingernail mark, right? But I can say it is consistent. And when we're documenting, we'll take typically 3 photos of an injury, 1 far away to show where it is on the patient's body, 1 up close, so you can get a better view of it, and 1 with a standard ruler that most forensic programs will use. And then we'll measure that and describe it as objectively as we can. But once again, we can't say, this is a handprint, this is a bite. I wasn't there, but I certainly can describe it and then give my opinion of, yes, this is consistent with a handprint, or this is consistent with a bite mark. So just please keep that in mind. You're not going to see us document bite mark. We'll quote the patient. We'll ask them, what happened here? They bit me. Okay, then I'll quote them, right? So I can speak to that later. Here's some extras, things to really keep in mind with strangulation. There can be immediate problems, right? They lost consciousness, or they're having paralysis, they're having a neurologic problem, they're having trouble breathing because of swelling. Maybe there's swelling inside the airway. Think about if you sprain your ankle, right? It swells. We get this inflammatory process that happens and it starts to swell. Well, what if that's happening inside the neck? I can't see that by just looking at you. So we do remind people in the next few days, if you're having difficulty swelling, having difficulty breathing, we want you to come back, okay? Because that is a potential delayed problem if it starts to swell. stable. Typically, you're going to see that there's no finite number on this, but you're going to see that in the first few days if they're going to have that complication. I talked to you about pneumonia. If somebody aspirated any kind of fluid, they could get pneumonia later on the next few days. So we just want to make sure that we are addressing that. There's potential of a stroke. It is not common, but there is always, that's just a risk that we want to keep in mind. Okay. Loss of consciousness, we went over that. You can see this stuff, strokes, seizures. That would be a long-term complication of damage to the brain cells. I don't have a lot of literature on that or experience in myself because most of our patients, they do okay. They're able to go home and they do okay. They may have some other problems, but the seizures and stuff like that, I haven't seen the patients come back with that. It is a possibility, and it's something we just need to keep in the back of our mind. I did just recently take care of a kid that is having seizures, and he was strangled as an infant, and they did say the seizures are caused from his strangulation abuse as an infant. So it can happen. We've talked about hypoxia, loss of oxygen, can cause memory problems. Their executive functioning, right? Making those higher decisions can be affected, and especially their attention span. So when you're talking to someone who's just experienced trauma, you know, if you've experienced it, you've seen, they cannot put things in chronological order a lot of the times, right? They can't give us this happened and this happened and this happened. Everything, their memories are all kind of scattered. Everything's all over the place. What they do remember better are senses. So what they saw, what they heard, what they tasted, what they felt, smelled, they do remember that stuff typically better than chronological orders. The arterial dissection that results in a stroke can appear later. It's not common, but obviously if that happens, that's a big deal. So it's something that we pay attention to and just talk to our patients about. And then I already talked about the airway compromise from delayed swelling is obviously a potential problem. Real quick before I move on, this arterial dissection, because I know someone's going to ask. So when we're looking at what kind of imaging diagnostics do we do with someone that's been strangled, there's different trains of thoughts out there. Different organizations will say different things. We are actually participating in a study. I have it on our last slide, looking at 1,300 of our patients that have been strangled in a 5-year time span and looking at signs and symptoms. And I'll tell you right now, not one of them has had a carotid dissection. Okay. And that's what you'll hear CTA, carotid angiogram. That is a CAT scan that's looking directly at the flow of the carotid arteries. Okay. So what we're finding is you don't see a lot of that. So that really needs to be, whether someone does a CAT scan, because that's a lot of radiation, right? Whether somebody's doing a CAT scan or not after strangulation, that's between the provider, maybe the forensic nurse, the patient need to have the conversation. So when someone loses consciousness, if they have any kind of paralysis, one side or the other, a neurologic deficit, they look like they're having a stroke clearly, or maybe a loss of bowel or bladder, a lot of our providers will do imaging there. They'll do a CAT scan there. Some providers will decide to just do, maybe they don't have a neurologic symptom, but they've got a lot of visible injury, which does not mean it's worse than no injury, but some providers will think that, and they may order like a CT of the soft tissue of the neck, a CAT scan of the soft tissue of the neck, or a neck x-ray. Those are all going to be fairly limited to signs and symptoms from strangulation. They can rule out, the CAT scan can rule out if there's damage to the artery at the time, a tear in the artery at the time, which would be a serious complication. I'll tell you, I've seen one, but it's a car accident. And I've seen one from a hanging. I've never seen one from a manual strangulation. They have happened in the past, and that's why it's a big talking point. Do you do that? Because if you miss it, right, that's a big deal. Or are we putting too much radiation on people that don't necessarily need it? So there's different studies going on. We're a part of one right now to try to get us some better answers, but not everyone is going to get imaging. Just know that that's going to be provider specific, and then what's going on with the patient. So those are very, very specific. Okay. Psychological impact, you guys know this, any kind of violence, but especially strangulation. These patients for years later can experience fear and depression, PTSD. I work with a lot of patients, a lot of kids I'm seeing now that are having PTSD from past traumas, nightmares, the difficulty concentrating and focusing, especially if you're having someone who gets strangled a lot, these repeat strangulations, they're in an abusive relationship. This is the norm. Think about how many times they keep getting this like deprivation of oxygen, even if it's not a lot, but they keep getting that over and over and over again. Eventually that is going to affect the long-term right? Capability of the brain. And they may have trouble with concentrating and focusing. Think about like concussions, people that keep getting concussion after concussion after concussion, which a lot of our IPV patients have as well. Eventually that's going to cause them long-term problems with their brain. So same thing we can see with these patients as well. And you can see the other things here. I think because of time frame, we're going to skip through this. Here is our study we're working on. If you have questions, you can ask us later. Hopefully we'll be done in the next couple of years to know a lot more. It'll be the largest study of living patients of strangulation, non-fatal strangulation. So hopefully we'll have a lot more answers in the next couple of years. And then a couple key points with strangulation. Please, please, please believe the person. This is a terrifying, very personal assault. I've heard some of the worst things talking to these patients about what they were experiencing during the strangulation. They may act drunk or dramatic is what people say. Oh my gosh, they're just so dramatic. Or no, they're terrified, or they've had a loss of oxygen to their brain. And so that's the physiologic response to that. You do not have to have visible injuries. 50% of the time, we don't have visible injuries when someone has been strangled. So when someone tells you this happened to them, just believe them. And I really, really encourage you to get this person to seek out medical care. Worst case, call us. We'll talk to the patient over the phone to let them know what we can offer and not offer. And even and help find a program that has a forensic nurse available to do these specialized assessments and care for these patients, because it is a big deal. Strangulation is a very big deal. The other thing I didn't put in here is we need to ask. Patients don't understand strangulation. People think strangulation is with a ligature. They don't understand that by a hand or a chokehold or someone leaning down and putting pressure on a neck is strangulation. That is strangulation. So when people say, were you strangled? They'll say no. And then I come in later and say, at any point, was anything around your neck or any pressure on your neck? Oh yeah, their hand. Okay. So they didn't realize, right, that's what strangulation is. The other thing is, especially with intimate partner violence patients, this has become the norm. So for them, it may not be a big deal. Well, I mean, this time he only strangled me. Last time, I mean, he punched me in the face, and that feels more important to them than the strangulation. So we need to be asking all of these patients at any time, was anything around or any kind of pressure on your neck? And then once again, just, I'm sorry this happened to you, and try to get the medical care. All right, we've hit our time. So does anybody have any questions for me? I tell you, I could talk for hours more. So
Is your contact info there?
Mine is not.
Okay.
I didn't put mine. That number earlier, there's 719-365-8333. That is the 24/7 forensic nurse line. So you will get a forensic nurse if you call that number. If they don't answer, it's because there was someone, just call back. I will tell you my email if you want to write this down. It's Andrea.Greco, Greco @uchealth.org.
I'll put that in the chat too for folks. So.
Okay.
All right. Any last questions for anyone?
No questions? God, I'm just that good. I'm just kidding. Please feel free to reach out, or if there's anything else that you guys want more about. I did not put a lot of things that would traumatize you guys in here. I saved those for medical people, but if there is more training needed or things like that, just please reach out. One of my colleagues is one of the state trainers now, and it is her job to provide education throughout the state. So we have the people to do it. If there's more education you want, please feel free to reach out. And I so appreciate everything all of you guys do.
Thank you so much. I hope everyone has a great afternoon, and thank you, Andy.
Bye.
Bye-bye.